One of your Apurba is Sastry Essentials of Microbiology, which is about lymphatic filariasis. In this chapter, we will be previewing filarial nematodes, Gaucheria bancrofti, and Brugia malai infections. First of all, starting with filarial nematode. Filarial nematodes are vector-borne parasites that reside in the lymphatic system, skin, subcutaneous tissue, and rarely in body cavities, and accordingly, they cause various types of clinical manifestations in man. Lymphatic filariasis. Filarial worms reside in the lymphatics, produce chronic obstruction and fibrosis of lymphatics. Agents include Vaucheria bancrofti, Brugia malai, and Brugia timori. They differ from each other in various properties. Cutaneous and ocular filariasis include Loa loa, Onchocerca volvulus, and Manzanella species, which reside in skin, subcutaneous tissues, and some in eyes and serous cavity. They produce various cutaneous and ocular manifestations. Morphology and habitat of filarial nematodes. Filarial nematodes are viviparous, exist in two morphological forms, adult worm and larva. There is no egg stage. Adult worm. Adult worms are slender, round, measuring 2 to 10 cm in length. Some adult filarial worms can survive for many years in humans, causing chronic obstructive and inflammatory conditions such as elephantiasis and hydrocele, a condition known as lymphatic filariasis. Larvae. Like other nematodes, there are four larval stages. The first stage of larva is called microfilaria. The third stage larva is called filiform larva, filariform larva, which is the infective form to man. Microfilariae. They are usually non-pathogenic, but sometimes hypersensitivity reactions can occur against the microfilarial antigen, resulting in tropical pulmonary eosinophilia (TPE). Microfilarial periodicity. It is defined as the time when most of the microfilariae are found in peripheral blood. Microfilariae usually reside in pulmonary blood vessels and occasionally come to the peripheral blood at different times, example daytime or nighttime, depending upon the species. Periodicity occurs due to biological and evolutionary coadaptation of microfilariae to the feeding habit of the mosquito. Culex bites in night, Aedes bites in daytime. However, other factors like sleeping pattern of the individual, temperature, and other climatic conditions also contribute. Now let us see the differences between various filarial nematodes causing lymphatic filariasis. First of all, Vaucheria bancrofti or the Bancroftian filariasis. The location is in lymphatic tissue of microfilaria is in blood, rarely hydrocele fluid and chylous urine. The microfilaria periodicity nocturnal is mostly the microfilarial periodicity is nocturnal, whose vector is Culex worldwide and Anopheles in rural Africa. The epidemiology is in cosmopolitan South America, Africa, South Asia. The rare subperiodic microfilaria periodicity, its vector is Aedes, and its epidemiology is in Pacific Islands and Andaman and Nicobar. Now, Brugia malai, which causes Brugian filariasis, is located in lymphatic tissue of an adult. Location of microfilaria is in blood. It has also mostly nocturnal periodicity, which with the vector Mansonia anopheles. Its epidemiology is in Southeast Asia, Indonesia, and India. The subperiodic rare periodicity is vectored by Colliquiledita and Mansonia. Its epidemiology is in Southeast Asia. Brugia timori, location of adult is in lymphatic tissue. Location of microfilaria is in blood. Microfilaria periodicity is nocturnal. The vector are Anopheles barbiosteris and epidemiology is in Indonesia. Now coming on to lymphatic filarial nematodes. Lymphatic filariasis is caused by Vaucheria bancrofti 90%, Brugia malai 10% and Brugia timori, which is rare. It is characterized by chronic obstruction and fibrosis of lymphatics leading to lymphedema, hydrocele, and elephantiasis. The existence of lymphatic filariasis has been recorded in ancient Indian, Chinese, and Egyptian writings. Indian physician Sushruta was the first to describe elephantiasis in his famous book Sushruta Samhita in 6th century BC. Madhavakara in 7th century AD described the disease in his treatise Madhava Nidhana. In 1709, Clarke called elephantoid legs in Cochin as Malabar legs. Okay, now epidemiology. About 893 million people in 49 countries worldwide are at the risk of developing lymphatic filariasis. In 2000, over 120 million people were infected, with about 40 million disfigured and debilitated by the disease. Southeast Asia accounts for the highest burden, comprising of 50% of the globally infected lymphatic filariasis (LF) cases, followed by sub-Saharan Africa, Pacific Island, some areas of South America and the Caribbean. Globally, 90% of lymphatic filariasis is caused by Wucheria bancrofti and the remaining by Brugia species, and in India the ratio is 99.4 and 0.6% respectively. India. It is estimated that about 650 million people are at risk residing in 256 districts or 21 states in India, accounting for 40% of the global burden. Highly endemic states are Uttar Pradesh, Jharkhand, Bihar, and West Bengal, which account for two-thirds of the lymphatic filariasis burden in India. Prevalence is low in northeastern states, Jammu, Kashmir, and Punjab. Bancroftian filariasis. Vaucheria bancrofti is the most widely distributed filarial parasite of humans, accounts for more than 90% of the world lymphatic filariasis. It is named after the scientists Voucher and Bancroft who contributed to its discovery. In general, Vaucheria bancrofti is nocturnally periodic except in Pacific Islands where it is subperiodic. Life cycle. Host and vector. Vaucheria bancrofti completes its life cycle in two hosts, man definitive host and intermediate host is mosquito. Culex quinquefasciatus is the principal vector worldwide. Rarely, anopheles in rural Africa or Aedes in Pacific Islands can serve as vector. Subperiodic Vaucheria bancrofti is transmitted by Aedes mosquito. Infective form. Third stage L3 filariform larvae are the infective form found in the proboscis of the mosquito. Now the microfilarial periodicity of filarial nematodes, let us discuss this first. The nocturnal microfilaria in blood peak at night 9 pm to 4 am. Examples are Vaucheria and Brugia. Diurnal periodicity, microfilaria in blood are present throughout the day and night, peaks at midday 12 noon to 2 pm. Examples are Loa Loa. Subperiodic periodicity is in the microfilaria are present throughout with the slight increase in afternoon 3 to 5 pm diurnal subperiodic or slight increase in the night 7 to 9 pm nocturnal subperiodic. Examples include Vaucheria transmitted through Aedes. Okay, now last non-periodic, no periodicity is noticed. Example Onchocerca and Manzanella. Now coming back to the life cycle, let us first discuss the human cycle. L3 filariform larvae gets deposited in the skin by the mosquito bite. Larvae penetrate the skin, enter into lymphatic vessels and migrate to the local lymph nodes where they molt twice and develop into adult worms. Adults lay L1 larvae. Adult worms reside in the lymphatics of lymph nodes where they undergo fertilization to produce L1 larvae, microfilariae. Male worms die after mating, whereas the female worms live up to 20 years. A gravid female worm can discharge up to 50,000 microfilariae per day. Microfilariae have a lifespan of up to 1 year. Pre-patent period, this is the time period between the infection, entry of the L3 larvae and the diagnostic detection of the microfilariae in the blood. This is variable ranging from 82 to 142 days. Mosquito cycle. When the mosquito bites an infected man, the microfilariae are ingested. Culex bites at night, whereas Aedes bites in daytime. Microfilariae come out of the sheath, penetrate the stomach wall of the mosquito and migrate to the thoracic muscle where they molt twice to develop into L3 larvae. The L3 larvae migrate to proboscis of the mosquito and serve as the infective stage to man. In this flowchart, we can see the life cycle of Vaucheria bancrofti. Starting from mosquito bite, microfilariae are ingested by the mosquito. L1 larva molt twice to become L3 larva infective form. Man gets infection by the bite of the mosquito, transmitting the infective form L3 filariform larvae depositing the skin. These migrate to the local lymph nodes. Then these L3 larvae develop into adult worms. Again, adult worms in the lymphatic system undergo fertilization to produce microfilariae, which produce L1 larvae in the peripheral blood. This is again transmitted by a mosquito bite. Now, the extrinsic incubation period under optimum conditions, the mosquito cycle takes around 7 to 21 days. Pathogenesis and pathology. The pathogenic changes occur as a result of inflammatory damage to the lymphatics, which in turn is due to summation of many effects such as tissue alterations related to migration of live adult worms such as lymphatic dilatation and thickening of the vessel walls. Tissue alterations related to antigen and toxic metabolites released from the dead adult worm. Secondary bacterial or fungal infections. Host inflammatory response to both live and dead parasites. Infiltration of plasma cells, eosinophils and macrophages in the infected vessels. This leads to toxicity of the lymphatics and damage to lymph valves, resulting in lymph edema of the limbs. As long as the worm remains viable, the lymphatic vessels, though damaged, still remain patent. However, the death of the worm leads to enhanced granulomatous reaction and fibrosis of the lymph vessels. This results in severe lymphatic obstruction. The lymphatic function is severely compromised. Endosymbiosis. Pathogenic Vaucheria bancrofti is found to be infected with a Rickettsia group of bacteria called Wolbachia and maintain an endosymbiotic relationship. It is proved that this symbiosis is essential for the parasite survival and pathogenesis. Age and gender. Microfilariaemia increases with age, starts at 5 years and peaks at 30 years. Males are more common affected than females, commonly affected. Hormonal factors in females may be attributed to the higher resistance to the infection. Host immune response. Both cellular and humoral immune responses are altered. Antigens of both adult worms and microfilariae are processed by the antigen presenting cells macrophages and presented to the T helper cells. The T helper cells are stimulated and differentiated into Th1 or Th2 cells. In early infection, amicrofilariamic individuals, both Th1 cells and Th2 cells are stimulated. In microfilariamic individuals, asymptomatic and acute stage, here Th1 response is downregulated and Th2 cells response is activated, which leads to elevation of IL-4, IL-5, IL-13 and interleukin-10, profound eosinophilia, increased parasitic specific IgG4 antibodies is observed, level of which decreases with successful therapy, hyper IgE levels. In chronic filariasis, there is an increased production of Th2 cells, including induced cytokines like IL-4, IL-5 and IL-13. There occurs elevation of parasite-specific Ig1, IgG2 and IgG3 antibodies. Now the clinical features, incubation period is about 8 to 16 months. Clinical manifestation can be categorized into lymphatic filariasis, topical pulmonary eosinophilia TPE or occult filariasis, and immune complex mediated manifestations. So firstly, the lymphatic filariasis. Lymphatic filariasis passes through 4 stages. Endemic normal. These are the people residing in the endemic area. Their prevalence ranges from 0 to 50%. They are not infected by the parasite. This might be due to various reasons: insufficient exposure, immunological resistance, or in the pre-patent period at the time of study. Asymptomatic microfilariaemia. In endemic area, many infected individuals do not exhibit any symptoms of filarial infection, but microfilariae can be demonstrated in the peripheral blood. They may show following features when examined: microscopic hematuria and or proteinuria, dilated and tortuous lymphatics visualized by imaging, filarial dance sign ultrasound showing motile adult worm in scrotal lymphatics. Next, acute filariasis, acute lymphangitis. It is characterized by recurrent episodes of filarial fever, which is a high-grade fever, lymphatic inflammation, lymphangitis, and lymphadenitis. Lower extremities are more commonly affected than the upper limbs. Lymph nodes are most often affected are the epitrochlear, axillary, femoral, or inguinal. The lymph nodes are firm, discrete, tender, and enlarged, while the lymph vessels are inflamed and indurated. In addition, lymphatics of the male genital organs are frequently involved that lead to funiculitis, epididymitis, and orchitis, not seen in Bruggen filariasis. Transient local edema, early pitting edema reversible on limb elevation. Dermatolymphangiosis, plaque-like lesion is formed over the affected skin with fever, chill, and lymphatic inflammation. In Bruggen filariasis, the episodes are more frequent and abrupt in onset. Next is the chronic filariasis that develops 7 to 15 years after infection. Chronic host immune response against the dead worm leads to granuloma formation and fibrosis of the lymph vessels, causing severe lymphatic obstruction and pedal edema. In this figure, we can see the clinical features of filariasis, which is elephantiasis and hydrocele of the scrotum. The manifestation of the chronic disorder in descending order of occurrence are: hydrocele, most common manifestation, accumulation of the clear straw-colored fluid in the cavity of tunica vaginalis of testes. Elephantiasis, swelling of the lower limb or less commonly arm, vulva or breast. Lymphedema is initially pitting type stage 1, which becomes non-pitting and irreversible on limb elevation stage 2, followed by brawny lymphedema with thickening of the skin grade 3, finally leading to fibrosis and fissuring grade 4. Chronic funiculitis and epididymitis and chyluria, excretion of chyle, a milky white fluid in urine that may occur rarely. This is due to rupture of lymph vessels into the urinary system. So this was the first clinical feature, which was lymphatic filariasis. Next comes tropical pulmonary eosinophilia TPE. TB is also called as occult filariasis, represents a hypersensitivity reaction to microfilaria antigen. Microfilaria are rapidly cleared from the bloodstream and filtered, lost and destroyed in the lungs, initiating an allergic response. Hence, microfilaria are not detected in the peripheral blood. Next, immune complex mediated manifestations. Circulating immune complex containing microfilarial antigens are found to be deposited in various organs such as kidney, causes nephrotic syndrome, hematuria and proteinuria. Joints, causes filarial arthritis of knee or ankle. Now coming to laboratory diagnosis of Bancroftian filariasis. Demonstration of microfilari by thin or thick smear stained with GIMSA or by QBC examination. Blood collected during night hours or daytime after DEC provocation test. Vaucheria bancrofti tail tip pointed free of nuclei. Brugia malai tail tip blunt, nuclei extends up to tail tip. Antigen detection, ELISA or ICT detects antigen by using antibody to OG4C3 antigen and AD12 antigen. Antibody detection, flow through assay using WBSXP1 antigen, luciferase immunoprecipitation system using WB123 antigen. Imaging methods, filarial dance sign in USG indicates serpentine movement of adult worms in lymphatics. Molecular methods, real-time PCR detecting genes such as SSPL repeat, PWB12 repeat or PWB35 etc. Other methods include eosinophilia and elevated IgE. Now lab diagnosis in detail. Microscopy to detect microfilari. Microfilari can be rounded in blood and occasionally in hydrocele fluid, urine or by other body fluids. Direct wet mount demonstrates serpentine movement of microfilari. Thin and thick smears, Leishman's or GIMSA staining can be performed to observe the sheath and nuclei of microfilaria. Microfilaria ranges from 1 to 1000 or sometime up to 10,000 microfilari per ml of blood. Concentration techniques. Blood can be examined after concentration techniques to increase sensitivity. Membrane filtration technique and not centrifugation technique. Collection time. It is critical and should be based on the periodicity of microfilari. For nocturnal periodicity, blood should be collected between 9 pm and 4 am. DEC provocation test is done to collect the blood in daytime. Patient takes a DEC tablet orally 2 mg per kg so that the nocturnal microfilari are stimulated and come to peripheral blood within 15 minutes to 1 hour. However, in case of subperiodic Vaucheria bancrofti, in microfilari level fall rather than rise after DC provocation. This test is contraindicated in Onchocerca and Loa infection. QBC, quantitative buffy coat examination. It involves centrifugation of the blood, staining with acridine orange stain and examination under fluorescence microscope. This technique is more sensitive than smear microscopy. False negative, microfilari may not be found in blood because of many reasons such as occult filariasis, chronic filariasis and endemic normal people, wrong time of blood collection. Now, microfilaria Vaucheria bancrofti. Detection of the microfilari in peripheral blood is diagnostic of filariasis. It measures 260 micrometer into 7.5 to 10 micrometer covered by long hyaline sheath. The head end is blunt while the tail end is pointed. In celiac space, the length and width ratio is 1:1. The nuclei are large, coarse, well separated, present throughout the body except near the tail end. Nuclei are also absent in few places where various primordial organs are present like nerve ring, excretory pore, anal pore and genital cells. It differs from the microfilari of Brugia malai in head and tail region. Antigen detection. Circulating antigens of Vaucheria bancrofti can be detected by using monoclonal antibodies against OG4C3 and AD12 antigens. Both ELISA and rapid ICT are commercially available, show 95 to 100% sensitivity and specificity. No antigen detection methods are available for Brugia infection. Advantages of antigen detection. More sensitive than microscopy. Can be detected in daytime. Antigens can differentiate the current from past infection. Antigen disappears after clinical cure. Can be detected in urine. Next, antibody detection. In endemic area, most people have a raised antibodies IgG due to the prior exposure to non-human filarial worms and cross reaction to other helminths. Therefore, antibody detection tests are useful only for epidemiologic purposes, seroprevalence studies. In non-endemic area, it may be of diagnostic value. In contrast, the detection of parasite-specific antibodies IgG4 has better diagnostic value as described below. Parasite-specific IgG4 is increased in active filariasis and less cross-reactive. IgG2 level appear to be elevated in patients with elephantiasis. The young people who are resistant to filarial infection in endemic areas often express protective anti-sheath antibodies. Though most tests lack both sensitivity and specificity, some newer methods, as described below, have showed promising results, such as flow-through assay detects total IgG antibodies to recombinant filarial WBSXP1 antigen. Luciferase immunoprecipitation system is another rapid test using Paucheria bancrofti WB123 antigen. Imaging methods. Imaging methods are useful for the following purposes. Ultrasound, it can demonstrate dilated and tortuous lymphatic vessels. Serpentine movement of adult worm within lymphatic vessels of the scrotum, called filarial dance sign, is positive for 80% of the cases. Lymphoscintigraphy of the limbs reliably demonstrates the functional abnormalities of lymphatics even in asymptomatic microfilariamic persons. X-ray can detect dead and calcified worms. Now coming on to the pictures, first of all let us discuss the difference between the microfilaria of Vaucheria bancrofti and Brugia malai. Okay, first of all the head end of Vaucheria bancrofti, it has a sheath, its cephalic space is 1:1 and coarse nuclei which are well separated. While of Brugia malai there is a sheath, cephalic space ratio is 2:1, darkly stained large coarse overlapping nuclei are there. Okay, next coming on to tail end. Of Vaucheria bancrofti, terminal nuclei are elongated, no nuclei at the tail tip, and the tail tip is pointed. About Brugia malai, 4 to 5 nuclei in the tail region, 2 widely spaced round nuclei in the tail tip. Okay. Now the features ABCD stand for size, periodicity, sheath, and habitat. So the size of Vaucheria bancrofti is 260, approximately 244 to 96 micrometer. The periodicity is nocturnal, it is sheathed, and the habitat is in blood. About Brugia malai, the size is 220, approximately 177 to 230 micrometer. Periodicity is nocturnal, it is sheathed, and habitat it is found in blood. Now this figure 37.4 shows microfilaria of Vaucheria bancrofti. Okay, the schematic diagram with the sheath, cephalic space, nerve ring, coarse well separated nuclei, excretory pore, then the genital cell 1, genital cell 2, 3, 4, cloaca or anal pore, and no nuclei in the tail tip. Next, in figure B, we can see the thick blood smear stained with Giemsa of Vaucheria bancrofti, and in figure C, we can see the thick blood smear stained with Giemsa of the Brugia species. Okay. Now let us come to the molecular methods. Molecular methods such as PCR and real-time PCR are available, which provide several advantages. Can detect low level of parasitemia, can differentiate past from present infection, can distinguish between filarial parasites. Useful for monitoring treatment response. Detects parasites in carriers. Other methods. Eosinophilia, absolute eosinophil count more than 3000 per microliter. Elevated serum concentrations of Ig more than 1000 nanogram per ml. Cellular assays, filarial skin test and lymphocyte response to filarial antigen, both are less specific. Biopsy of enlarged lymph node to demonstrate adult worm. Urine examination reveals microscopic hematuria and proteinuria. Now coming on to the treatment of bancrofti and filariasis. Diethylcarbamazine (DEC) is the drug of choice for treatment of filariasis. It is given 6 mg per kg daily for 12 days. It can kill both adult worms and microfilariae. However, adult worms are cleared slowly. Albendazole is given 400 mg twice daily for 21 days. It has also demonstrated efficacy against adult worm and microfilariae. Ivermectin 0.4 mg per kg single dose can kill microfilariae but has no effect on adult worms. High rate of recurrence occurs, hence not used in India, used only in Africa. Doxycycline is given to target the intracellular Wolbachia. It shows significant microfilarial activity like DEC. Penicillin secondary infections due to bacteria such as streptococci can be treated with systemic antibiotics like penicillin till the infection subsides. Prevention. Vector control. Anti-larval measures, they are highly expensive, hence mainly restricted to urban areas. Chemicals used are mosquito larvicidal oil, pythrum based oil, pyroxene oil E, organophosphorus larvicides like phentoin, temphos. Okay, and anti-adult mosquito measures like pythrum spray can be used. However, DDT and hexachlorocyclohexane (HCH) are not effective. National Vector-Borne Disease Control Program. The National Vector Filariasis Control Program in India is active since 1955, which was integrated with National Vector-Borne Disease Control Program (NVB) DCP in 2006. Hathi Pav Mukt Bharat. India under NVB DCP has launched a massive campaign in 2015 for achieving filaria-free India named Hathi Pav Mukt Bharat. It aims at assisting the filariasis elimination program of India. Elimination of lymphatic filariasis (ELF). Global program to eliminate lymphatic filariasis was launched by WHO in 2000, aiming at global elimination by the year 2020. In India, ELF is in operation since 2004 in parallel with global strategy, MDA strategy. WHO recommends mass drug administration (MDA) once in a year to all people at risk in the endemic areas for a period of 5 years. MDA regime. Single dose of DEC 6 mg per kg plus albendazole 400 mg is the MDA regime of choice in all endemic areas of world including India, except in onchocerciasis endemic areas where ivermectin plus albendazole is given, in Loa endemic area in which albendazole is given twice per year. Triple drug regime. WHO recently recommended IDA regime, ivermectin plus DEC plus albendazole. It is implemented in selected districts of India. Anti-Filaria Day. It is observed on 5 June globally. In addition, the National Filariasis Day in India is celebrated on 11th November every year. Assessment. The impact of MDA is assessed by conducting microfilaria survey by peripheral blood smear examination once in a year per month prior to next MDA, followed by transmission assessment survey by antigen or antibody detection during post-MDA period. Global LF elimination study status. Till date, 16 countries achieved the lymphatic filariasis elimination status. 7 additional countries are in the verge of elimination. Preventive chemotherapy is still required in 49 countries. India LF elimination status. In India, 5 states, Assam, Tamil Nadu, Goa, Puducherry and Daman Diu stopped MDA after achieving elimination status. Now coming on to the second topic, which is Bruggian filariasis. Brugia malai accounts for 10% of lymphatic filariasis, named after his discoverer, Brugge, 1927. Epidemiology. There is considerable overlapping in the geographical distribution of Bruggian filariasis and Bancroftian filariasis. Brugia malai occurs primarily in eastern India, Indonesia, Malaysia, Thailand and Philippines. It shows 2 types of periodicity in microfilariemia. The nocturnal form is more common, transmitted in areas of coastal rice fields, while the subperiodic form is rare, found in the forests of Malaysia and Indonesia. In India, the major states involved are Kerala, Odisha, Assam and West Bengal. Life cycle. The life cycle of Brugia malai is similar to Vaucheria bancrofti except vector. Mansonia is the main vector of the nocturnal strains. Anopheles and Aedes can also transmit the infection. The subperiodic strains are transmitted by Coquilidita and Mansonia. Reservoir. Humans are the main reservoir except for the subperiodic strains of Brugia malai where monkeys, cats and dogs are the animal reservoirs. Clinical features. Both lymphatic filariasis and tropical pulmonary eosinophilia syndrome are observed in Brugian filariasis. Clinical features are similar to Bancroftian filariasis except more frequent episodes of acute adenolymphangitis, adenitis, femoral nodes and filarial abscesses. Chronic manifestation lymphedema or elephantiasis occur less frequently. The genital involvement is not seen. Elephantiasis swelling is limited to leg below the knee and chyluria does not occur. Lab diagnosis. As in Bancroftian filariasis, the diagnosis of Brugian filariasis depends on microscopy. Microfilaria in blood can be detected by peripheral blood smear examination. The microfilaria of Brugia malai. Detection of microfilaria in the peripheral blood is diagnostic of filariasis. Measures 220 into 5 to 6 micrometer in size, covered by hyaline sheath. Cephalic space is longer. Nuclei are large, coarse, darkly stained, overlapping and present throughout the body, extending till the tail region. Tail tip is blunt, contains 2 widely spaced nuclei. Antibody detection methods. 2 methods are available. Both are currently used under Filariasis Elimination Program ICT for screening and ELISA for confirmation. Brugia Rapid. It is an ICT detecting parasite-specific IgG4 antibodies against recombinant BMR1 antigen of Brugia malai. BM14 ELISA employing recombinant Brugia malai antigen BM14 is available. However, there is no antigen detection method is available. Imaging methods like ultrasound can be employed. Molecular methods, as described earlier, PCR and other molecular methods can differentiate between Brugia malayi and Vaucheria bancrofti. Treatment for Brugian filariasis is the same as for Bancroftian filariasis, except that frequency of adverse effects following DEC medication is more. Therapy should be started with lower dose. Prevention same as for Bancroftian filariasis, both chemoprophylaxis and vector control. Hemolopistia plants. In South India and Sri Lanka, where the Mansonia is the main vector, breeding is best controlled by destroying the supporting plant Pistia stertoris from all water collections by herbicidal agents like phenoloxine 30 and shell weed killer T. Lastly, Brugia timori. Brugia timori infection is limited to the Timor Islands of southeastern Indonesia, transmitted by Anopheles barbitoris. Morphologically, microfilaria is similar to that of Brugia malayi, except that it is longer, 310 micrometer, and more nuclei at the tail region. Clinical feature, laboratory diagnosis and treatment are similar to that of Brugia malayi. Okay, so this completes our chapter lymphatic filariasis. Now let us come to questions. A 35-year-old female from the village of Bihar came to the hospital with a history of fever and on and off for the past 1 year and recently developed unilateral swelling of the left lower limb. Her blood sample was sent for peripheral blood smear examination but revealed a microfilariae 250 micrometer in length, tail tip pointed, free of nuclei. Okay, this is an infection of filaria. Okay, so Vaucheria bancrofti can be the etiological agent. The diagnosis, life cycle and treatment of all that we can write. Short note on Brugian filariasis, of course, can be written. Now coming on to the MCQs. Microfilaria of the Brugia malayi differs from that of the Vaucheria bancrofti by all except it has a core overlapping darkly stained nuclei. True. Tail tip free from nuclei? No. Brugia malayi tail tip has two spaced nuclei. Okay, so this is the correct option. Cephalic space is longer, yes, and possess secondary kinks. It is true. Which of the following microfilaria comes to peripheral blood in the daytime? That is diurnal periodicity. Lower shows the diurnal periodicity. Okay, so this completes our chapter. Next we will be starting with fungal infections. Okay, so thanks for watching. Like, share, subscribe.